Hello, my name is Jeff Taylor, and we're here at the closing of the 22nd CROI here in Seattle, Washington. And today we're going to be talking about aging and HIV. We have with us today some esteemed aging researchers, Dr. Peter Hunt from UCSF, Dr. Alan Landay from Rush University in Chicago, and Dr. Seema Desai, also from Rush in Chicago. So welcome, and thank you for joining us today. So obviously, you know, as we age with the epidemic, both ourselves and the patients living with HIV, it's become a more important issue as people are enjoying better health on the one hand, but as they get older, they're developing kind of aging conditions in somewhat different ways. Do you want to kind of speak to what struck you this year as being important issues that were raised at CROI and the data that was presented?
Yeah, so multiple morbidities that we normally associate with the aging process, like heart disease, a lot of non-AIDS cancers, osteoporosis and fractures, are increased in the HIV-infected population, and there's an increasing awareness that this is not just entirely explained by the increased prevalence of smoking and other risk factors, although that clearly contributes and is an important, modifiable risk factor for a lot of our patients that we need to focus on. There is an increasing awareness that HIV causes inflammation in the body, and that overactivity of the immune system takes its toll on the body in multiple organ systems.
And this is even when people are fully controlled.
This is even when people have an undetectable viral load on therapy, and so there's a lot of work now trying to understand why that's happening and to develop effective interventions to reverse it. But in the meantime, really focusing on those modifiable risk factors like smoking, exercise, and other things that can probably have make a big difference.
And I think we now recognize, as Peter said, inflammation is one of the key elements here in this, and we think that we're really thinking more about the innate immune system as driving, and perhaps one of the main drivers of the inflammation. And the question is, can there be, even beside the modifiable risk factors, smoking, alcohol, could we do simpler interventions like statin therapies, and beginning to think about where does statins fit into the whole armamentarium of therapies, or aspirin, some of the simpler ones, before we maybe move on to the more the biologic approaches to try to block some of the cytokine pathways like IL-6, which is shown up to be such an important outcome modifier.
So as Peter and Dr. Landay said, I think this CROI, most of the presentations that show an association of inflammation with comorbid conditions that happen despite heart. What we knew thus far was that immune activation was associated with different comorbid conditions like cardiovascular disease, neurocognitive outcomes, as well as diseases, frailty, and many diseases in the women's as well as men's cohort. What comes out this CROI, I think, is that there is a lot of data that shows that innate immune activation contributes to inflammation, and mostly monocyte and macrophage activation. There are various studies that were presented that this CROI that showed the association of soluble 163, which is a monocyte activation marker, with cardiovascular outcomes, with neurocognitive outcomes, with liver disease, as well as heavy alcohol use. So certainly biological pathways, as well as the modifiable behavioral risk factors, are indeed contributing to innate immune activation. So this is like a double-edged sword. On one hand, your innate immunity that is supposed to protect you is abrogated because of the chronicity of virus across that you are experiences across so much time, as well as lack of T-cell effector function. So T-cell senescence on one end and inflammation on another kind of contributes to comorbidities. And I think that's something that is presented this CROI, which is innate immune activation association with comorbid conditions.
And one thing to add to that is that the importance of innate immune activation versus what we call adaptive immune activation, which is T cells and B cells that are supposed to recognize specific types of infections. The adaptive immune activation, T cell activation, and other immunologic pathways that cause defects in your response to vaccines, defects in your response to infections, might be more relevant in resource-limited settings where people still die of infectious causes, and that's I think there were at least a few posters at this year's CROI that measured a lot of these same markers in resource-limited settings, and whereas IL-6 is such a strong predictor of clinical outcomes in North American cohorts, it's not quite as strong in a lot of resource-limited settings, whereas the adaptive immune defects seem to be more important there, and that may speak to these infectious complications which are still very real.
Well, it's gratifying to see this research being done in resource-limited settings because as the rollout of ARVs has become successful, they too are seeing kind of a graying of their own epidemic, even in sub-Saharan Africa. So,
and I think, given the healthcare, the implementation that we are seeing, these other comorbid conditions more and more, like diabetes and heart disease. So they're not just, as was said, some of them are becoming increasing in prevalence. And I think as we begin to roll out our programs for ARVs, we'll also roll out better health care to deal with these other comorbid conditions, so we can take care of their HIV disease, but also their other conditions, whether they may have diabetes or cardiovascular disease or bone disease. So I think it really provides a changing healthcare environment on the global basis to deal with these others. And once we've built the kind of infrastructure to help deal with HIV, then I think the other non-communicable diseases, because really on a global basis, we're going to be seeing that the NCDs or non-communicable diseases are on a rise, and that's what when we talk with the WHO or UNAIDS, that's where a lot of the focus is going to be going in the future, dealing with these outcomes and how they're going to impact the global health arena.
Well, yeah, indeed, if there's going to be a silver lining to the horrific AIDS epidemic, I think it's the increase in capacity and medical infrastructure that's being built throughout the resource-limited world. It's gratifying to see. So, we talk about all the bad things that are happening, and of course, people living with HIV want to think about what interventions they themselves could do. And you mentioned the Reprieve trial, the possibility of using statins. Do you want to expand somewhat on that trial, where it is, and if people could enroll in it?
Well, I think,
so the Reprieve trial is going to be 6,500 patients with treated HIV infection who don't have high enough risk for cardiovascular disease, to be recommended a statin currently. So less than a 7.5% 10-year risk.
And that's measured by the Framingham guidelines?
By the updated coronary heart disease risk estimator, which is in the new ACC guidelines. So patients who are at a relatively lower risk will be randomized to either get, meaning 50-50 coin flip, get the statin drug or a placebo sugar pill for up to 6 years. And so we'll see if this strategy will decrease heart disease risk. Many of us are even more interested in whether giving a statin, which not only lowers the cholesterol level but also lowers inflammation, whether that impacts non-cardiovascular diseases like cancers, non-AIDS cancers, osteoporotic fractures, etc., and overall functional status even. So Seema talked about frailty.
Right. So if at all inflammation is indeed a common detrimental pathway associated with multimorbidities, then as statin would be just not only limited to CVD, it could have application beyond that. And adding an adjuvant could really show some promising results. So we look forward to the trial.
Yeah, and I think we'll be able to recognize the what are the multimorbidities as we
Right.
begin and really begin to think about the integrated care across these different morbid conditions. So somebody doesn't just come in with cardiovascular disease or just with bone disease, they really come in with multimorbidities. And so I think that's the question of the pathways that we think are common or not with each of these clinical outcomes, and how do we measure these is really what I think is going to be the challenge going forward. And I think for clinicians, as Peter may want to comment, is when he's seeing the patient in front of him in clinic, you know, what does he do for that patient in terms of their current risk and where they should go, and should they start aspirins or other anti-inflammatory. And even when we're thinking now, when we start our ARV therapies, will people's immune responsiveness, because we now recognize subsets of patients among our virologically suppressed patients, and Peter Hunt and Michael Letterman have done a lot of elegant work to look at defining these immune non-responders, virologically suppressed patients in whom the inflammation persists at a higher level than those who respond immunologically. And I think they create a very interesting group of patients whom, for many of our newer anti-inflammatory approaches, we're targeting.
Mm-hmm. Yeah, I think that patients who have a less robust CD4 count recovery during therapy are at higher risk, and also there's more and more appreciation of the CD4 to CD8 ratio. So we also measure the CD8 counts, and the CD8 counts are actually expanded in HIV. Having a low CD4 to CD8 count ratio may be even more predictive of risk than just the CD4 count itself. But right now we don't have any proven interventions that we can use in the clinic. I can't tell a patient that, gosh, if I give you in someone who has a low estimated risk for heart disease, I can't tell them that taking a statin or taking aspirin is going to improve their risk of disease. We don't know that yet, and that's why we need to do these studies so we can get evidence to support that. Because any medicine has potential side effects and cost, and so we want to make sure that we're actually improving health, not just making biomarkers in the blood change, but we want the health of people living with HIV to improve.
Well, and certainly pill burden is a big issue for people, especially those who've been living a long time with HIV, who remember the bad old days when they were on fistfuls of pills several times a day, and that's kind of a reminder of their disease, and they look forward to having once a day HIV regimens and not having to take many other pills.
But speaking of which, there are things that can be done now in the absence of pills to lower risk, right? So exercise, for example, there was a study at last year's CROI, a pilot study showing that exercise tended to decrease inflammatory markers, and there are more posters now, and some observational studies.
A lot of alternative approaches.
Would you like to expand on some of those? Because I think that's one thing people with HIV really want to hear is what they can do.
Balanced, a good nutritive diet. Lot of papers on exercise, as well as behavioral changes, where you could, you want to smoke less, drink less, and everything that attributes to your immune activation or inflammation. If you could at least take away that burden, I guess it would really, lifestyle change could help a lot.
And we're looking at other sources that drive from the nutrition. I mean, one of the interesting areas, and there were a number of posters this year on the human microbiome that I think is also getting more recognition. It's had a lot of recognition outside of the HIV field, where it's an association with metabolic diseases and in association with those kinds of outcomes. And now we're seeing that the changes that might occur in our GI tract, and as we know, we are more microbial cells than human cells, and they have a great impact on us.
Some more than others.
Yes. It depends on what we've eaten. But anyways, it is a great opportunity, because as we think about it, as Dr. Desai said, the nutritional, interventional, or other concepts, one can start to look at other ways of modulating health that may have an important outcome. We're again in very early days here in terms of thinking about it, although we are pursuing in some of our clinical trials arena, we have groups actually that came from last year's meeting on the microbiome to look at prebiotic and probiotic approaches. So I think there are great opportunities to think about that, but just even simple nutrition. And like you said, something that we don't often think about is just what do we eat and how does that affect?
Mother's advice to eat right, to exercise.
That's right.
It's going to serve us well.
Yeah.
You talk about the gut biome, and we've been hearing a lot in recent years about microbial translocation and how sometimes the gut is not working in our favor in HIV, and how that can affect both the inflammatory response you were talking about and disease itself. Do you want to expand on that at all?
Sure. I mean, it's still very much out there. There were even presentations as recent as this morning looking at other approaches using cytokines. Interleukin 21 was an actual talk this morning from one of the groups in Atlanta that talked about how to use that cytokine to repair the gut translocation and what's going on there. So I think, yeah, we are targeting clearly, still thinking about the gut. I think it's also important that these microbial products may affect the liver and other organs, and so we're interested in this. And so it's not just the HIV patients, but perhaps also the hepatitis C patients. And in this meeting, we are, and I think as you looked at the meeting, as we think about aging, we have to think about co-infections.
And a lot of papers on HCV.
And HCV, and I think maybe Seema could comment since she's been studying and doing a lot of work on
a lot of work on
sepsis.
Hep C and microbial translocations. So because your HIV augments microbial translocation as well as Hep C. So if you have a dual burden, it kind of increases your gut permeability and results in increasing immune activation and inflammation. So it is important, is to control, in heart control patients, to study what HCV does by itself and look at pathways that whether you could block those pathways. And we did find elevated enhanced apoptosis due to HCV infection in control patients.
And does HPV have a similar effect on
HCV?
HPV. Hepatitis B.
HPV also would have the same effect as HCV.
Yeah, so and I think another virus that Peter's had a lot of
CMV.
love for is CMV, and he might want to comment because I think that's again one that's been associated with the aging population, but also more so in the HIV groups.
Yeah, there was a whole session on CMV and HIV, a poster discussion, and there was some data from an Italian cohort of people living with HIV who either had CMV, which is the vast majority, versus people without CMV, and people with CMV were at a significantly higher risk for particularly vascular complications, so heart disease.
Well, most people with HIV have CMV as well, correct?
Yeah, that's right. There's well over 90%, probably more like 95% have, and it's not causing any symptoms in most people with a reasonably healthy immune system, but it's taking its toll on the body and maybe contributing to immune activation, and there's some suggestion that it might increase the risk of vascular disease. And so when we see increased cardiovascular disease in HIV, we think, it must be the HIV, but it's also possible it's working indirectly through this other virus, CMV.
And even HCV.
Right.
Yeah,
We've
actually
actually, so I think, we need to, and because we have, and we've heard a lot at this meeting about the therapies for HCV, and when we talk about cures, we talk, certainly a cure in HCV, and a lot of the focus there, so that it'll be interesting to see in those populations that are co-infected, once we start implementing and thinking more about these other viruses, what the long-term, are we going to help our patients even more so with HIV in terms of the residual, how much, and I think this is a question we're all very interested in, how much of that residual inflammation of HIV patients on therapy is due to these other co-infections, and we don't have that data, right?
And soon we'll have the opportunity to see it.
And I think we're thinking about other therapies, and perhaps in the CMV area in the future as well.
Yeah.
Terrific. This has been terrific. Thank you very much.
Thank you so much.
Thank you so much.
Thank you so much.
This has been very enjoyable. Thank you again.